Class is now starting. All attendees are in listen-only mode.
Good afternoon. Today's December 18th. I'm Donna Will, Professional Development Coordinator for the Developmental Disabilities Administration. We welcome you to the Friday series of DDA updates. Our presenters for today include Bernie Simons, the Deputy Secretary for DDA, and our special guest, Dr. Kenneth Feder. We also have Chioma Ani, who is with DDA, and Valerie Roddy, Director of Fiscal and Operations, Rhonda Workman, Director of Federal Programs, Patricia Sastoque, Director of Programs, and Joseph Walburn with DDA ISAS Division. So before we begin, I'd like to go over a few things about the webinar. All participants are in listen-only mode. There are two handouts for the webinar, and you can find those in the handout section in the panel to your right, and they can be emailed upon request. We will be recording the webinar and post it on the DDA website. Questions can be typed in the question box in the webinar panel, and we will answer those towards the end of the presentation. So now I'd like to introduce Deputy Secretary Simons. Good afternoon.
Good afternoon. Thank you, Donna. And so as we look at the agenda, I just want to make some opening remarks that today marks our 28th webinar in our last webinar for 2020, and I want to thank everybody for your continued supports and attending these webinars. I hope that they've been very helpful and informative. We have received a lot of positive feedback. We'll continue to do these webinars in 2021 since we're still in the pandemic, and even though we're getting vaccinations in a vaccine into the state. But obviously, it's going to be a while before we get enough to inoculate everybody, if that's the appropriate term. I'm sure Dr. Feder can correct me if I'm wrong on that. You'll see in today's presentation the dates and times that we have allocated for these meetings for the next 6 months. And today, we're going to give you the update on critical issues, and I'm going to then turn it over to Dr. Feder, who's joining us today, and he'll talk about isolation versus quarantine and preparing for the holidays. Next slide. So as we've said in the past, we continue to remain committed to everybody in supporting health and safety and well-being for everyone. Individuals that we provide supports to, their families, our providers, people who are micro boards, people who self-direct, and that we're all in this together, and we need to be very careful with the upcoming holidays. Please continue to practice all your social distancing, your washing hands. If you saw the governor yesterday, he's taking the numbers from 25 back to 10 for gatherings. And we need to keep everybody safe and healthy. And I want to take this opportunity to wish everybody a happy and safe holiday. I know that this past year has been very challenging since March for everyone. And I want to express my gratitude to you and remember all of those people that we have lost, individuals as well as our staff and our agencies and the people who live in Maryland and across the country that we've lost to the coronavirus. Again, I want to thank you for your partnership that we've been doing, and for the people that we support and their families. I want to thank you for your patience and working with us and being a good partner as we design services. You've been very creative and innovative and staying connected and being safe at home, and reminds us all of the deep strength of relationships, and your resilience has really been inspiring and outstanding. Our direct support professionals are our frontline heroes, obviously, are going into work all of the time, day after day, to make sure that the people that they provide supports to not only cared for, but there's a visible commitment that everybody has had in providing support. So I want to thank you for that. Case management's done an outstanding job. I think it's our first line communication, providing the wellness checks. When we asked providers to give us updates of where we are within the people they provide supports to in their agency, it's one thing, but a majority of our people don't live in residential services. If you look at our numbers, about almost 18,000, there's about 6,400 that are in residential. So that tells us that the majority of the people are basically living either alone or with somebody else, or with family, etc. So we did ask the CCSs to do the wellness checks, and they did that, and obviously have been amending person-centered plans to make sure that everybody's got the appropriate information that they need. Our providers have risen to the challenge. They've been extremely innovative, continue to work to provide supports to individuals. And I want to say that I'm hopeful that with next year, we can think that maybe there was a silver lining in this pandemic, because it's shown us as a community how we can provide supports differently to individuals and adjust as we adjusted to these challenging times. We've been able to provide a lot of supports and services through the use of technology. We've got a lot of positive feedbacks, and as we move forward in the future, we will continue to have that as an opportunity. We want to make sure that, as we did in the past, we became an employment first state. We need to become a technology first state and see what people would want for technology in order to gain more independence, etc. Next slide, please. So, as I said earlier, the governor basically did a press conference yesterday, and I mentioned that, from 25 to 10, but there was a lot of other announcements that he did with $180 million towards economic relief, 40 million of which he said in the slide is available from his presentation yesterday to the developmental disability providers. And he said that would cover the 4% increase. So instead of it going into effect in July of 2021, it will go into effect in a few weeks of January 1. That $50 million also goes for hotels and hospitality businesses, $30 million for restaurants, 15 for entertainment venues. I mean, everybody's struggling. If people are staying at home, people aren't going out. Hopefully, as people have been saying, support your local businesses and your restaurants by, if you can't go in and eat, which you probably wouldn't, you can do takeout. So, and we need to do that with all of our businesses. And so again, and then $5 million he talked about for rural businesses. So that's just an overall recap. And again, his video is available on that. Next slide, please. So there's a link here, and it goes to the governor's office about quarantining and testing. And it basically talks again about what the governor talked about yesterday, that Marylanders traveling out of state, people coming in, what that looks like for testing, and within 72 hours before you travel into Maryland. People, especially when we look at the way we are situated here between the small area that we are in the Mid-Atlantic, and looking at Delaware, D.C., Virginia, that part towards Alexandria, etc., West Virginia, and Pennsylvania, that we bought all of those other states. So we need to make sure that we're well aware, and hopefully people are not traveling and staying at home for this holiday to remain safe. Next slide, please. So this gets into the link that I was mentioning about large gathering, and recommended to avoid indoor gatherings, limit it to the size of 10, limit traveling only for essential purposes only. And this is also refers to the Secretary care matters on mandatory testing after traveling and all of that. So next slide. This last week, we did the 6th round of PPE. We weren't sure we were going to get a 6th round. We were very successful early on getting our 1st round and through the last 5. This last round, number 6, was almost double the size that we've had prior to. And I encourage everybody to, if they need more, to work with your local health departments. If you need additional PPE, and actually reach out to your regional director also and have a conversation with each of the regional directors. And that the other issue is we need to recognize, and I think the governor said this a few times in his presentations, I think probably about 3 or 4 weeks ago, that he was encouraging the counties to buy PPE with the CARES Act money that they had. So hopefully that the counties are doing that and getting it to their local health departments so that we can have PPE, in particular gloves, gowns, and masks, etc. Next slide. So at this time, we've got the vaccination plan, and I've heard from a lot of people who are advocating strongly for where are we with the IDD population. We know that we've got 155,000 COVID-19 vaccines that are coming in that will go to hospitals and nursing homes and first responders. The state's working to get those homes and hospitals the doses as soon as possible. I think we've got it out. I think there was a couple of folks who were getting their shots on TV the other day at in Baltimore. And again, as we continue to get more information and know where we are, we don't think that we're going to be too far down the line, but we don't know where that is yet. Obviously, people have been advocating strongly, as I said, to many folks, including myself, the secretary, governor's office, etc. So, next slide, please. Appendix K, we're hearing from the Center for Medicare and Medicaid Services that it looks like they're going to extend beyond the 1 year. As you recall, it went from March of 20 to March of 2021. And now, since we are still in the pandemic and March isn't that far away, it looks like CMS is going to say Appendix K is going to be tied to the length of the public health emergency, and that they're going to have probably maybe even an additional time period after that so that states can take a look at what was in the Appendix K and what would be then maybe an amendment to our waiver, as an example, or what would we not be doing anymore that was particular to that public health emergency. And it met the needs during that time, but it wasn't at the forefront like technology, like people are asking to continue that. So we'll evaluate that as we go along and keep everybody informed as we learn more from CMS and we engage to find out what individuals and families are looking and providers are looking for. Next slide. So we did revise Appendix K, as we've been talking about, and submitted it to CMS. There was a whole issue about consecutive days for the retainer days as a requirement, and that we've requested that be removed so that providers can access the total amount of days that they can receive. And again, community living group home is up to 60 days. And remember that that's 30 days of retainer and 30 days of quote unquote absence days that are already within our home and community based waiver, community pathways in particular. And that all of the other services that we have for day, personal supports, et cetera, will be 30 days. And so again, we're looking at this with multiple episodes, and there'll have to be certain guardrails that are in there. That's a requirement from CMS if you've been on their website. And then the other thing is that the providers are going to have to attest with those guide rails, etc. So next slide, please. So let's talk about the guide rails for a second. You got to acknowledge that these payments would be subject to recoupment if inappropriate billing or duplication payments for services occurred. It's going to be attested to that from the providers that they will not lay off staff and that they will maintain wages at the existing levels. And they need to be able to move forward with including but not limited to unemployment benefits, etc. And then on Wednesday, the department received follow-up questions to our amendment that from CMS, which we're answering with Medicaid. They actually got it, and that the response is expected to be sent out today. And once we get the Appendix K, we'll provide information and get it out, and again come up with maybe further. We will come up with further guidance around how to attest to the guide rails and the guidance, etc. Next slide, please. So we did Amendment 3, and it was submitted to CMS the last day of October. And we received questions from them at the beginning of December. And obviously, some of these questions were on what do we look like? Because if you recall, we looked at the nursing services as a standalone. So they had follow-up questions such as, tell us more about nurse consultation and nurse case management, etc. So obviously, we'll continue to receive the same amount of services, but everybody should have more choices in the way they receive those services. And hopefully it'll be more clear than a bundled service. So the other area is we need to take a look at our proposals on support telehealth and remote learning, etc., technology, and all of this stuff. So we had some questions about that, and we'll continue to talk about that as a service delivery option, and we'll describe steps to ensure that some of these devices that are being utilized will be HIPAA compliant, etc. And then also maybe talk about some rate methodology and what does that look like for purchasing of these types of devices, etc. So our DDA waiver Amendment 3, the effective date is a few weeks away, January 1. And again, we'll keep everybody informed of where we are when we get more information from CMS and the approval, etc. Next slide, please. So in previous webcasts, there has been some concern raised by folks with this missing time request for the direct care staff who are providing personal supports in home and clock in and clock out. And if there's a misstep or there's a missing request, what does that look like? As earlier when the people who are on this webinar, Joey from the ISIS team is on to answer any questions at the end of this presentation. But they've changed their policy, and it's personal supports using ISIS. We'll have in-home supports, and they've extended the grace period for the DDA providers missing time requests through the end of February 2021, and that they are they won't track the numbers, because at some point in time there was you can't have more than 6, and I know that there was a lot of concerns about that with a learning curve and a new system, etc. So in their communication, they basically said that they will not be looking at the total number of more than 6 until we get to March 1, so people have a little more time to experience where they are and see if there are any other issues that need to be identified in additional trainings. Next slide, please. So then again, you'll see on this slide is the letter with the changes and the updated policies that of what I just talked about with the MTRS and what that looks like for payment and missing time sheets, etc. So we'll continue to work with them. We appreciate the partnership that we have with Medicaid on this whole EVV and personal supports. They've had a lot of experience doing this. They've been doing this for multiple years. And so when DDA had to respond and implement this due to the federal legislation that was passed by the U.S. House and the U.S. Senate, again, reminding everybody it was supposed to be implemented last January, and there was an extension and a grace period to this January. I think that we were in a good position in this state where we have had our Medicaid partners basically having experience with this for many, many years now. So that was it was good for us in DDA. We weren't being the newbie and trying to figure out what we were doing when we had a lot of guidance and support from them. Next slide, please. So we'll give you some updates on where we are as of yesterday, the 17th. The South region had 406 confirmed positive cases of people we provide supports to, 156 negative, 7 are pending, and we have had 20 people in supports who have passed away. In the East region, we have 73 positive, 293 negative, 4 pending, and we have had 3 individuals pass away. Central region is 534 positive, 807 negative, 71 pending, and we have had 31 deaths. And in the West region, we've got 140 confirmed positive, 310 testing negative, 6 pending results, and 5 people who have passed away. When it comes to staffing, this is DSP, but it could be more than that because we know that a lot of agencies and other folks have had people who are not quote unquote classified as direct support professionals actually functioning in those roles. So in the South region, we've had 282 people test positive staff with 5 deaths, 158 staff in the West region with 2 deaths, 133 positive, and no deaths in the East. And in the Central region, we have had 472 tests positive, and we've had 2 people pass away. Next slide, please. All right, this is the standard slide that we've been using since day one, with the pie chart on the left showing about this almost 18,000 people that we have in supports, and then the number of people who have tested positive, and it's 1,212 or 6%. And that's an increase since our last report of 1%. So I don't know why that has happened. We were staying at 5 for a long period of time, but maybe it's a result of after Thanksgiving or everybody's numbers are going up. We see that daily with the reports in the state and nationally. The chart on the right shows the number that have tested positive by region from November 12th through yesterday. And then it drills down and it shows actually the numbers and the increases. And I want to direct your attention to Central went up by 95, West by 45 and 47. I'm sorry, South was 45 and West is 47 and 0. So we are seeing a reflection of the general population to our population of our about 18,000 people in supports that we have. Next slide, please. So the chart on the left is from December 4th to yesterday, the 17th. And we have had 10 participants that have passed away of the 1,153 who tested positive. And the pie chart on your right shows those individuals who have passed away, which represents 5% of our overall population. And so, again, we've had 59 pass away, and that was an increase of 10 from where we were in previous reporting periods. So I just want to make sure that that's clear. So from the 4th of December to the 17th, we had 10 individuals pass away. And again, that the pie chart shows a total of 59, or about 5% of the, as I said on the earlier slide, 1,212 people who have tested positive. So the next couple of weeks will be critical with the holidays. And again, I'm asking everybody to be safe and social distance, wash your hands. Please adhere to the executive orders and governor talking about 25 back to 10, and be very, very, very careful. Now I'm going to ask Dr. Feder, who's graciously accepted our invitation, and he's been with us quite a few times in the past, and we appreciate all of his guidance that he's given to us and all the support, not just on these webinars, but even outside the webinars when he gets inquiries from us, for either from families or direct support for providers. So again, so thank you, Dr. Feder, for joining us today.
Thank you, Deputy Secretary Simons, and thank you again to everybody on the webinar for joining. Before I start, I just want to echo Deputy Secretary Simons and others who speak, just to commend everybody for the incredible work that's going into caring for the folks who you're serving right now. What's happening right now is, unprecedented and maybe the most dangerous this pandemic has been since it started. And everybody is exhausted, and yet they continue to make Herculean efforts to keep their residents and staff safe, even in the face of shock and tragedy and other challenges. So thank you for everything you're doing. It is making a difference. As we'll talk about, there is light at the end of the tunnel, but we have to get through this toughest period first. And so I'm just gonna, today all I'm gonna do is update and clarify some key elements of guidance that I think have caused confusion. And so this will be almost like a mini epidemiology lesson for those who are interested, and then talk a little bit about what this means in terms of guidance for the holidays. Slide, please. Okay, so one thing I just want to highlight before I go any further is that we have added small updates to our checklist of recommendations for group homes. So please download that latest checklist, take a look at the changes. They are small, but it's a good chance to review all the things that are there. The small changes deal with basically just, encouraging more testing, although not requiring it. And then also, some recommendations that are pertinent to the holidays, and then some recommendations that I'm going to talk about here that have to do with the differences between isolation and quarantine, and when you don't have to exclude your staff versus when you are recommended to exclude your staff, but you don't have to do it, versus when you really, really do have to exclude your staff. So, okay, so that's going to be a major topic today. I'm going to talk about isolation versus quarantine. What is the difference between these two things? And I hope if there's one thing you walk away from today with, it's the notion that isolation and quarantine are not the same, and understanding what this difference is when we talk about the difference between these two things, why it's important to you and the people you serve. Talk about what is isolation, what is quarantine, talk about when exceptions to each of these things are permitted, and then finally wrap it up by talking about how this is relevant to preparing for the Christmas holiday. Slide, please. Okay, so this is a more general point, but as an epidemiologist, I think this is important for us all during the pandemic, because we use both of these words a lot. And they're not always used consistently by the media, which creates a lot of confusion, but understanding the difference between the two of them would really help us understand the other guidance that we're getting from CDC and other places, so that we can better understand what makes sense for the folks who you're serving, for your staff, what it is we're saying should be done. Okay, so isolation and quarantine, they both mean separate yourself from others, but they refer to two different groups of people who have two different sets of guidance. Isolation is what we say somebody needs to do when they have tested positive for COVID-19 or a dangerous communicable disease. Isolation means you actually tested positive. Quarantine is something different. Quarantine is for a person who has not tested positive for COVID-19, but has had a high risk exposure. So you might say, hang on, people who have not tested positive, what's going on here? Well, the idea is you've done something that makes me think, in the next 2 weeks, I really think you could test positive, even though you haven't yet. And so we're going to jump straight ahead and put you in a quarantine. Okay, so a quarantine is for people who have not tested positive, but have had a high risk exposure. Isolation refers to people who have actually tested positive. So both mean separate yourself from others, but they're for very different reasons. Slide, please. So let's talk about what the isolation guidelines are, okay? Because I think it's important to understand that because these two things are triggered by different events, to isolation, actually testing positive, quarantine, being exposed and thinking you might test positive, but not having it actually happened yet, we give different guidelines because isolation is triggered. So who should isolate? Well, anyone who tests positive for COVID-19 should isolate. And how long should they isolate? Well, there's detailed CDC guidance on this you can take a look at. You can also follow up if you have questions about this, and this is in the checklist. But if you have symptoms, you have to stay in isolation until 10 days have passed since symptom onset. And if you have no symptoms, you have to stay in isolation until 10 days have passed since that positive specimen was collected. So, I have no symptoms of COVID-19, but I work in a home where somebody's tested positive for COVID-19, so I'm required to go get tested. I go get tested, and on December 20th, I test positive for COVID-19. If I never show any symptoms of COVID, I go into isolation immediately. If I never show any symptoms, I'm good to go 10 days later on December 30th. If I start to show symptoms on December 13th, that's when I start counting my 10 days. I have to wait until the Okay, plus to go back, get out of isolation, you have to not be sick anymore, so you have to have no fever for 24 hours. Plus, you have to feel mostly better. I think you've all seen from experience now that usually people are better within 10 days or they're very sick and therefore they're. Okay, so can isolation be shortened, or are there exceptions? So this is the most important point. The answer is no. Isolation can almost never be shortened for your residents or for your staff. If you have COVID-19, we expect you to be alone, away from other people, not working. If you are in an absolute staffing crisis where every single other option available to you has been exhausted, call your local health department and they'll walk through those options with you. They'll see if they have other supports that they can provide you that you might not have on your own. And then we can discuss the possibility of shortening isolation for staff who maybe have tested positive but have no symptoms. But this is almost never permitted. Slide, please. Okay, but now let's talk about quarantine. This is when you're exposed. Who should quarantine from COVID-19? Well, ideally, we want anyone who's had a high-risk exposure to COVID-19 to quarantine. So and keep in mind, this you haven't tested positive here. You've just had a high-risk exposure, and so you're preemptively separating yourself from others. That's a quarantine. So what is a high-risk exposure for a client of DDA, for a client of your programs? So most obviously, you live in a group home, another resident or staff in your home tests positive for COVID-19. That's a high-risk exposure. Another possibility is you're outside your home, working or attending a day program, and someone with COVID, you have close contact with somebody who had COVID-19 outside your home. That's another way you could have a high-risk exposure. Another way is that happens, but you don't know it happened, but you get a call from the local health department, from a contact tracer who notifies your program that somebody in your program was a close contact of somebody with COVID-19 in the community. So you're told by a local health department, well, you don't know this happened, but we're telling you it happened. Somebody in your program was exposed to COVID. Finally, there are two other things that we consider high-risk exposures. One is a client received medical care unrelated to COVID-19 that required an overnight stay in the hospital. So basically, we're saying if you're spending a night in the hospital, you could potentially be exposed to COVID-19 in the hospital. We think you're probably not. Hospitals are pretty safe at this point. They've got their infection control protocols down. But just to be safe, that's something that should trigger a quarantine. And finally, and this is new, and this is relevant to the holidays, a client spends time dining with or sleeping in the homes of family or loved ones. In other words, we're saying there's so much COVID-19 out there in the community that if you go out and you visit your family or your loved ones and you either dine with them, which requires everybody to take their masks off, or you spend the night in their homes, that's a high-risk exposure, which we recommend be followed by quarantine. And I'm going to come back to that again when we talk about our holiday recommendations. But just keep in mind for a moment, these are the 5 things that I would consider high-risk exposures for a client of a DDA program. Slide, please. Okay, so who should quarantine? Folks with high-risk exposure. What does that mean for staff of a DDA program? So for staff, that means you had close contact with someone COVID-19 during work, and you didn't use your proper personal protective equipment. So that's really important because your staff are likely going to be working with people who have COVID-19 at some point. And if they use proper personal protective equipment, they don't have to quarantine. And in fact, they will need to continue working to provide you with adequate staff. So as long as people are using their personal protective equipment correctly, the assumption is they're protected. And so there's no recommendation of quarantine for staff who have close contact with somebody with COVID-19, but use their personal protective equipment correctly. If you didn't use your personal protective equipment correctly, that's when we recommend that preemptive quarantine. Even though you haven't tested positive yet, see if you can not work. Okay, so another possibility is the staff has close contact with someone with COVID-19 outside work. Outside work, you're probably not wearing personal protective equipment, so therefore you're exposed. And then finally, of course, staff is told by a health department contact tracer they were exposed to COVID-19 outside. So these are 3 ways that a staff could be considered having a high-risk exposure to COVID. Slide, please. Okay, so how long should a person quarantine? So the goal is 14 days. 14 days following their last exposure. Note that that's longer than the 10 days of isolation, which is a little counterintuitive, and I'm happy to explain why if anybody has a question at that, but the recommended quarantine is 14 days, assuming they don't test positive, because if you test positive, then you start isolation. Do people in quarantine need to be tested for COVID-19? Yes, absolutely. If you're going into quarantine, you should go get tested for COVID-19 because you want to know if you're actually infected and you should be following the isolation guidelines. And then finally, here's the critical difference. Unlike isolation, can quarantine be shortened or are there exceptions? The answer is yes. There are 2 very important exceptions. The first is an exception specific to healthcare workers. If you have staff who, all other things being equal, they probably should be quarantined because they were exposed to COVID-19. They've never tested positive, but they were exposed to COVID-19. But you need those staff to work because otherwise your homes won't be adequately staffed. Your staff can keep working. You don't need to ask the health department for permission. That's a change that's in the guidance. We put in there, you no longer need to ask for permission. We recognize these decisions need to get made fast. You do not need to ask the health department for permission for your staff who have not tested positive to come out of quarantine or to not complete a quarantine. Note that that's very different than isolation. If you actually test positive, there are no exceptions. You must go into isolation only if every single other possible option completely that could be come up with is exhausted. Call your local health department contact during that outbreak and you talk to them about that possibility. Quarantine, you haven't tested positive, you were just exposed, that's a lower standard. If you need those staff to work during a quarantine period, they may do so. And then the second is that more generally, I just want to highlight this for you. CD's put out some more general options for shortening quarantine. So if you have people for whom you say, okay, I want them to do a quarantine, but maybe we'll cut it short. So an example of this would be like, you have a resident, why would you might do this? So maybe you have a group home resident who has a job, like they work on a cleaning service or something like that. They learn they're exposed on the cleaning service. And so they're quarantined to their home. but you want them to be able to go back to work because that's best for their development, for their income, whatever else. You might consider some of these CDC options for shortening their quarantine. And basically these options are, you test the person, and if they test negative after a certain period of time, you can cut that 14 days short to 7 days. And the details are in there, and I'm happy to answer questions about it. But the safest choice is always that full 14 days. Okay, so the second one's less important, but I just wanted to hide it to you because it is there. It is in CDC guidance that you can sometimes cut these quarantines short. But the first one's really important. For your staff who are exposed to COVID-19, but don't have any symptoms and haven't tested positive, you can bring them back to work if you need to. But if they're in isolation because they actually tested positive, you can't do that. Staff who test positive have to be in strict isolation. Okay, slide, please. Okay, this just emphasizes the same thing. Most important distinction. If your staff are exposed to COVID-19 and are in quarantine, you may bring them back to work to care for residents. If needed, you don't need to ask permission. If your staff tested positive for COVID-19 and are in isolation, you may not bring them back to work. You may ask permission for an exception from the local health department. It might be granted, but it usually won't be. Usually they'll help you find another option. Slide, please. Okay, so now I just want to talk briefly about preparing for the holidays. So the situation during the holidays basically is that, a lot of people are going to want to go home and visit their families. They're going to want to see loved ones during the holidays, which is totally understandable. The problem is that there are probably more people infected with COVID-19 right now in Maryland than at any point during the pandemic. So any non-essential travel, by which I mean travel that isn't necessary for survival, for medical care, for obtaining basic necessities, etc., is risky. Particularly if you're spending time eating or sleeping in the homes of somebody who you don't regularly live with in your group home. Because they could have COVID-19, and that allows COVID to move outside of one household and into another household. So we want to offer some recommendations about how to approach this, okay? Thinking about this on a tiered scale, discouraging folks from traveling, but then recognizing that some families or individuals may make different choices, and talk about how you can protect the other residents in your program if you do have folks who are making this choice. So first of all, we encourage you to continue to prohibit visitors in the group homes you actually operate. In other words, folks may leave your home to visit others, but don't allow visitors in your home. That puts the other folks in the home at risk. Only essential personnel should be going inside the group home or people who live in them. Okay, the safest choice for residents: do not visit loved ones during the holiday. There's currently a CDC advisory against holiday travel. Maryland Department of Health advisory also against holiday travel. We recognize that this is a substantial emotional burden, and I don't want to trivialize that. I'm sorry, and to be frank, I'm feeling it myself. We didn't visit family for Thanksgiving, and we're not going to again during the winter holidays, which is pretty tough for my grandparents. But we recognize that should we have COVID-19, we don't want to give it to them, and we can't know for sure because this disease can be carried by asymptomatic people. So the safest choice: do not visit loved ones during the holiday. So there are certain groups of people who are prohibited from visiting their loved ones during the holiday who have to stay in their group home. So that's basically people who have actually tested positive for COVID-19. So obviously, test positive for COVID-19, can't leave your home. And if you're in quarantine, so somebody else in your group home has tested positive for COVID-19, so your home is during that 14-day quarantine period, right? You haven't tested positive, but you've been exposed. You can't go visit your loved ones while you're quarantined. So no isolation breaking, no quarantine breaking, just to do holiday visitation. Slides, please. Okay, so in addition, we would encourage you not to permit any visitation of one of your residents to a household, to family members or loved ones, where any of the following is true. The person they're visiting has tested positive for COVID-19. So you don't want your people you care for visiting people who are supposed to be in isolation. They shouldn't be visiting anybody who's been tested for COVID-19, but is still awaiting their test results. Because if they got tested, that means they're concerned they might have it, and we want to know for sure they don't before the visit happens. Someone has recently been exposed to COVID-19 or extracted to quarantine from their health department. Okay, so we don't want anybody being visited who's in quarantine. They may not have tested positive, but they've been told by their local health department, we think you might get sick soon, so stay away from other people. So nobody should be visiting a household where somebody's quarantined. And finally, someone has any symptoms of COVID-19, So, your residents shouldn't be visiting somebody who has symptoms of COVID-19 because that person could have COVID-19, your resident could get it, they could bring it back. Slide, please. Okay, having said all of this, you may have residents whose families choose to bring them home for the holidays. And if so, choose to bring them for visits for the holidays, recognizing they've been separated from their loved ones for an extremely long period of time in dangerous circumstances, and this is very painful. And we understand that. And so, these are some guidelines to consider in the event that you do have residents who against the CDC guidelines, do leave and go visit their families for some time. So what should be done? So if you have a group home who's diagnosed with COVID-19 while they're visiting family, they cannot return to their group home. They have to complete their isolation with whomever it is they're visiting. So if they're living with their family and they catch COVID-19 while they're living with their family, they shouldn't come back to the group home with COVID-19. They should stay with their family until they complete their recovery, or wherever their family wants them to, but they shouldn't be coming back to their group home, exposing the other people and the staff who work in them. Group home residents who are exposed to COVID-19 while visiting with family shouldn't be coming home. They should do their quarantine while they're staying with their family. So that means, if you have a resident, they go home to stay with their parents, say, and while they're with their parents, one of those parents tests positive for COVID-19. Well, even if your resident tests negative, they should wait 14 days before coming back to the group home. They shouldn't be coming back to the group home while they're in quarantine because they were exposed to COVID-19. Now, when they do come home, we recommend that they complete a 14-day quarantine. So what that means basically is you go visit your loved ones, that's fine. You come back to your group home, but for the next 2 weeks, you should mostly stay in your room. Staff should be using full personal protective equipment while caring for you. Be staying away from other residents. And you certainly should not be, you're prohibited from participating in activities outside the home. In other words, simply visiting your loved ones during the holidays is a high-risk exposure. And so when you come back, we're going to try to keep you separated from the other residents in the home and keep you out of home activities for 2 weeks. In addition, before your residents come back to your home at all, make sure they're tested for COVID-19. So you can verify, it's not perfect, but at least they have a negative test before they come home. Okay, that way you'll catch the folks who may have been infected during the holiday. They'll stay out of the group homes. And finally, once they're home, even if they've already been tested, during that 14-day quarantine period, you can take them for a second test to make doubly sure that they weren't infected while they were at home. And if they test negative a second time, you'll feel a lot better. Doesn't change the recommendation for a 14-day quarantine. They should still stay away from their housemates for 14 days, but at the very least, more information is always better than less. So basically what we're saying is, best choice is not to go home and visit your loved ones during the holiday. You can't go visit your loved ones if you or they have COVID-19 or have been exposed to COVID-19. If neither of those is true, you choose to visit your loved ones. We're going to assume that visit is a high-risk exposure. You do the visit. When you come home, you do a 14-day quarantine when you're back in your group home. You get tested for COVID-19 a couple of times. Make sure you didn't get it while you're out there for the holidays. Slide, please. That wraps up everything that I wanted to say. So I don't know if I can take questions now or if...
Thank you, Dr. Feder. Really do appreciate you joining us today, especially during this holiday time and wonderful guidance. I do have several questions for you. I'm going to ask just one question of Joey in reference to LTS of Chioma, and then we'll go to your questions because you have lots of questions in the chat. For Joey, in reference to LTS of EVV, for clarity, is if a person is receiving virtual services and personal supports by 2 staff members in a day, if we are unable to enter the second shift in the day into LTSS until after the first one is marked paid, that is considered an adjustment and does not fall under the 30-day grace period for an MTR? Yes? No?
Yeah, I can talk about that a little bit. So if you enter service on a day, then come back a few days later or maybe in the next month, then you would be correct. That is an adjustment that you're making. You're adding time as long as it's for that same client. you're adding time to that day that would then be recalculated and sent off to be adjusted within our MMIS system. If you look at the policies that we sent around, adjustments are not held to that same monthly deadline. Yes, that would be accurate. You'd have a year, I believe, for adjustments.
Thank you, Joey. Sheila, do you want to add anything to that? Okay, I'm going to go ahead and then ask Dr. Feder several questions you have in the chat. And one of them is, what is the recommendation for agencies currently serving community individuals in small groups, like face-to-face settings? Is it suggested to continue or temporarily suspend face-to-face services at this time?
I think we're talking about non-residential services. Is that the question, like day program activities or something like that?
Yes. Mm-hmm.
Yeah, sure. It's a good question. So at this time, we haven't asked folks to cancel those services. So I'm not going to give a blanket recommendation about that. In part because counties may choose to make decisions about this, right? So counties may choose to make more or fewer restrictions based on the circumstances that's in their county. And so I don't think it's my role to say, give a blanket recommendation about those services, also because those services can vary dramatically. What I'll say is that, so first of all, I would be lying if I didn't say that by definition, if you don't participate in certain activities outside your home, you're safer than if you're, right? Like if you don't participate in activities outside your home, you're safer than if you do participate in activities outside your home. That's a fact. Having said as much, people benefit from participating in activities outside the home, developmentally, behaviorally, whatever. It's good for them. And also we recognize their staffing challenges. So, there's just, people need people to continue attending day programs and other things because that's what they have adequate staff for. So I think the way I would see it is, if you are continuing to operate those kinds of programs, it's worth reviewing and doubling down on the safety precautions for those programs, and then also considering who can safely attend those programs, right? So ideally, we want attendees of those programs to be wearing masks, to be practicing social distancing, and then for the staff to be very strictly using their personal protective equipment at all times that they're in the program. And so this is a good time to think about the structure of the program, right? So we've had day programs that I've helped other folks with where we've said, do most of the people attending wear masks? And they said yes. Well, most of them do, some of them don't. So we said, well, okay, given the level of spread that you're concerned about in your community, maybe somebody has tested positive in your community concerned, maybe people who can't wear a mask shouldn't participate in a day program. Or maybe they need to participate in that day program. And so if they do, they should be in a separate room, right? Maybe if you have separate rooms, like for example, this was a program where they mostly do arts and crafts. The people who are, and they have different spaces. We said the people who have masks can be in the big space, but then the people who can't wear masks can be in private. And then similarly for staff, there's never a bad time to double down and reinforce proper donning, doffing, wearing of personal protective equipment. And finally, just the thing that I'll add, I'm sorry. Another thing that you can do is you can enhance testing, right? So, if you have residents who are participating in a day program, maybe just start testing them on some quasi-regular basis, just to see if anybody's COVID-19, so you're screening and catch it earlier. Finally, of course, we can never do too much symptom screening. So making sure that nobody ever attends a day program if they or somebody they lived with has symptoms, right? So that really increases the safety of programs. Same goes for staff. Those symptom screenings, they're not perfect, but they do make a difference, particularly in complement, with everything else and testing. So what I would say is I'm not going to say don't operate the program. It is very dangerous out there right now. If you're choosing to continue to operate a program, it's a good time to reinforce safety measures, think about how they can be strengthened, and then think about, are there people who just can't safely participate in this program? Basically because they can't wear a mask and they can't socially distance because they cannot follow instructions and there's not sufficient space in the program. Finally, just one thing I want to touch on that's given me a chance to talk about is that I think there's a perception that that's been out there that if you're 6 feet apart, from all other human beings, you're safe. Because that's the social distancing guideline, and that's false. Being 6 feet apart from somebody makes you safer. It doesn't make you 100% safe. Particularly in an indoor environment with another person without a mask, there's always some risk of COVID spread. Indoor environments are much less safe than outdoor environments. Masked people are much safer than unmasked people. So outdoor masked activities, good. Tough to do things outside right now. So if your only protection is in an indoor environment, my residents are 6 feet apart from each other, that's lowering their risk, but it isn't that much protection, particularly in an indoor environment with people who are not.
Thank you. You have several questions here, and they're popping into this chat as you're talking. Do you have to have 2 negative test results before isolation can stop? Providers are being told by some local health department that MDH is requiring this.
If you're in isolation, meaning you've tested positive for COVID-19, after 10 days have passed from the start, so the start either means your symptoms started or if you never had symptoms from the day your specimen was collected, you're good to go. Most of the time. Every once in a while, there's some exceptions. If you have an immunocompromised resident, if you have a resident who had a very severe illness and they were in the hospital, but for some reason they came home early, then you want to, the local health department will help you, and you probably want to consult with the resident's physician. But no, once you test positive for COVID-19, testing should not be used to inform the decision about when that isolation period ends. You don't need to test negative twice. You don't even need to test negative once. You just wait out that 10 days and for your symptoms to go away and for you to feel better. The repeat testing guidance is old. It's months old. It was out there. It basically shouldn't be used anymore. The only time we use that repeat testing is if there's like healthcare personnel and we want to get them back to work sooner and we want to rush them back to work. So we keep testing them over and over again to see if we can clear them sooner than 10 days. That's not the case for your residents. And so that shouldn't be done. And you're welcome to follow up with me about this, but if there's a local health department that is advising that folks need to be retested, I think they shouldn't be advising that anymore. If you have tested positive for COVID-19, you just wait it out. If you're in quarantine because you were exposed, remember that again, that distinction between isolation and quarantine. If you're in quarantine because you were exposed, then you need to be tested because we want to know if you actually have COVID-19. Once you've got it, no more testing. We know you have it, just wait out the duration of the illness and then you're good to go. And that's based on CDC guidance.
Thank you. There's several on the retesting about the 10 days of isolation without any symptoms. So should a client, can a client tested positive for COVID-19 be retested after the 10 days of isolation without any symptoms?
They don't need to be tested again. You test positive for COVID-19 and you go 10 days without symptoms, you're good to go. There's no need to test that person again. After that period, they can't infect other people. They cannot infect other people. So if you have a client who tests positive for COVID-19, they absolutely need to be in isolation for 10 days. But if they never show any symptoms during those 10 days, they're good to go.
Okay. There's one, and this is an unusual, just some folks are asking about what about recommendations for dogs or family pets to go outside periodically during the day. What is the probability that they would bring the coronavirus into the home? Are you familiar with any cases or any recommendations that you can give?
Did you say something about dogs at the beginning? About pets?
An animal, yeah, their dog.
Oh, okay, yeah, sure. So the best kind of activity is solitary outdoor activity, or activities with solitary, but I mean like accompanied by staff if you need to be accompanied by staff. So if you can take a walk.
Question, Dr. Feder, the question is the person is afraid that the dog's going outside and they can bring the virus to the.
Oh no, they can't. Great question. Great question. Great question. No. So dogs, there's no evidence of COVID-19 being transmitted from dogs to humans. In very, very rare instances, there might be some dogs who have had COVID-19. They don't seem to be able to give it to humans. So dogs pose no risk. So the dogs can go in and out, and dogs can live their lives as normal. We're not concerned about pets, and in fact, that's a great way for folks to spend their time and find comfort in a very challenging time. So dogs are great. No concerns about dogs at all. Sorry, Patricia, go ahead.
Hello, guys. Sorry. There is a lot of questions here in the chat, and we got to our time. So what we'll do, as we've always have, is we will send the questions to Dr. Feder, and he will provide a response to us, and then we will share it with you all so that you can see his response to your questions. So thank you all, and have a wonderful holiday season. And Dr. Feder, thank you for joining us.
Thank you very much. Have a nice day, and take care. Stay safe, everybody.
Thank you.